Yes, sir.
Yeah, shall we start?
Yes, sir.
Okay, we are going to start. Okay, till now, till last class, we have completed about the anatomy of the facial now, as we have seen. So that we should have basic idea of what is the function of facial now. From pons to parotid, it is going. Second thing is, it is more commonly a second arch nerve. Okay, second arch nerve. So facial now, especially having motor things, that is special visual difference from brachial apparatus. Okay, so for muscles of facial expression, number one. Number two is that, so we have got the crying, we have got the lacrimation, we have got the salivation. So wherein you should have the, as you know, that general visual difference. So that is about the greater superficial petrosal nerve, and also the efferents going towards the salivary glands, that is to contract, that is the parasympathetic system that is contracting the salivary glands, that is the chorda tympani, as you know that. And then the other components, like you should know, you should have the sensation from the posterior superior part of the meatal wall, that is general sensory afferents. Okay, that is one thing which is important for the sensations. So like these are the different components that are present in the facial nerve. So we'll have a overview of these components. This is one nice video which I've taken from the net, of course. So we'll see once about this, and then we'll go for the paralysis, it causes, what is neuropraxia, axonotempsis, neuronotempsis, and what is the Sunderland's classification, and what about the causes, the etiology of paralysis, and how do you tackle the paralysis, and what are the tests that are to be done for the paralysis, and what are the confirmatory tests, how do you to see for a CT scan, and what are the reasons for various paralysis of facial nerve, and then the surgical aspect and the medical aspect. So normally facial palsy is a regular term. Palsy is something problem to the nerve. So wherein which includes complete palsy is facial paralysis, and partial one is going to be the facial paralysis. Paralysis something which is related to partial one. So we'll see the components video once, and then we'll go to the facial nerve.
Anatomically complex of all the cranial nerves, because it transmits 4 different types of innervation, and its branches take varied courses through the skull.
So how many components are there? Means 4 components are there.
Nerve. The first component is special visceral efferent, or SVE, innervation to the muscles derived from the second pharyngeal arch. This includes all of the muscles of facial expression, plus 3.
So you are expressing the muscles with the face. Some expressions are given, all the things, almost nearly 42 muscles are helpful for this facial expression. You should have it in mind. So that is, they are present only in the face. So they are special, they are visceral and efferents. Efferents is something related to your motor system. So that is branchial apparatus. Second arch gives rise to this. As you know, that stapedius is also second arch muscle, and as you know, stylohyoid muscle and posterior belly of digastric also same second arch muscle. All those muscles are by means of this special visceral efferents.
Others: stapedius, stylohyoid, and the posterior belly of the digastric muscle. These are regular striated muscles, just as you find in the limbs and trunk. Their designation as special visceral efferent simply reflects their origin from the pharyngeal arches rather than from myotomes. The second component of the facial nerve is general visceral efferent, or GVE innervation, to 2 pairs of.
So you want to cry, and you want to salivate. Okay, while you are crying, your saliva also comes. Remember like that. So while you are feeling bad, your facial expressions are bad, and then you are crying, and then your saliva is coming. Both are linked together.
Parasympathetic motor ganglia in the head, the submandibular ganglia, and the pterygopalatine ganglia.
This pterygopalatine ganglia is the largest ganglia in the head and neck. Very important. The other name is, it is also called as the pterygopalatine ganglia, ganglion of hay fever. Okay. Spinopalatine ganglion. So pterygopalatine ganglion, ganglion of hay fever, spinopalatine ganglion, all means the same. When you are crying, that is hay fever, that is you have got a lot of dust to your nose, palate, pharynx, larynx, all these things are stimulated by different nerves, especially the taste sensation from the palate and then soft palate are also taken by these means of pterygopalatine ganglion through this greater superficial petrosal. You should have it in mind. Okay.
The third component is special visceral afferent, or SVA, taste sensation from the anterior.
And this is very important, taste of the anterior two-thirds of the tongue. So while crying, you are putting some chocolate, so to console the cry. For example, anterior two-thirds of the tongue, you are tasting the chocolate by means of this chorda tympani now, which is supplying, which is carrying the taste sensation from anterior two-thirds of the tongue. So posterior one-third is glossopharyngeal, as you know. So chorda tympani, anterior two-thirds is second arch, posterior one-third is third arch, glossopharyngeal.
Or 2/3 of the tongue.
So this is very important. Like the very first class I have covered is about the branchial apparatus. So you should have basic idea of branchial apparatus. So 1,000 times also you read, it is not a waste, because you are understanding the concepts of head and neck by means of branchial apparatus.
Finally, the fourth component of the facial nerve is a small amount of general somatic afferent, or GSA, innervation to a patch of skin over the mastoid process and auricle. This innervation is not clinically relevant and is often excluded in descriptions of the facial nerve.
So general somatic afferent by means of vagus, auricular branch of vagus, the Arnold's now, it goes through that and then takes collections through that. So facial nerve has got connections even with all the nerves. So now even the proprioception is also, there is some amount of connection between the trigeminal nerve and all the nerves are connected. That is fifth nerve, that is seventh nerve, that is the ninth nerve. So as you know that these are all related to branchial arch development only. Okay.
We will include it here only for the sake of completeness. Now let's look at the origin of the facial.
So you can see that how it is going to be originating, and then how it is going to be going to all the processes, and how it is related to this, all these connections. There is 4 connections of the facial nerve. You can just see with all the branches. So please keep an eye. This is all there in the internet also, but thing is that for the sake of completion, you have to understand things. So the experienced pattern like us, you have to get orientation through this, and then you can see it many times. Anyhow, I'll send the link also.
Nerve and the routes that these 4 types of innervation take to reach their targets. The cell bodies of the SVE neurons are located in the brain stem, in the motor nucleus of the facial nerve. The cell bodies of the GVE neurons are also located in the brain stem, within the superior salivatory nucleus.
So when you want to cry, okay, so general visceral efferents, as you could see, so superior salivatory nucleus, a part of it will be the lacrimal nucleus. So superior salivatory nucleus, and this is SVE, that is motor nucleus. As you know, I told you in the lower pons it will be there. So brainstem includes midbrain, pons, and medulla. Midbrain, pons, and medulla, about which the lower pons, lower part of the pons, this will be there, and the exit of the facial nerve will be through the pontomedullary junction, PMJ.
Finally, the cell bodies of the GSA and SVA neurons are located in the geniculate ganglion, which is positioned deep with.
So GSA and SVA. So SVA is for the taste, that is the taste sensation, as you could see. So I told you the palate, soft palate and hard palate, the sum of sensation is carried by this geniculate ganglion through this greater superficial petrosal nerve, and including the lacrimation also. So GSA is general somatic, the general sensory afferents. Okay, as you could see, they will be linked with this particular geniculate ganglion. So geniculate ganglion is a one which is giving the greater superficial petrosal nerve. So first bend of the facial nerve in the particular temporal bone is called as geniculate ganglion, GG. GSPN is a branch of GG. GSPN is a branch of GG.
Then the petrous part of the temporal bone. These sensory neurons send their proximal process to the solitary nucleus in the brainstem. All of these different components of the facial nerve come together at the brainstem, and together they enter the skull at the internal acoustic meatus.
So this is the internal acoustic meatus, wherein these particular nerves are getting and entering into these things, so that all these components together they join, and then they form the bundle of the facial nerve along with nervous intermediates. As I told you, nervous intermediates, all the sensory components except the motor component, they are called as nervous intermediates of Risberg. Okay.
Even at its origin, the facial nerve proper is anatomically subdivided. The GVE, SVA, and GSA components are grouped together as the nervus intermedius.
As I already told you, nervous intermediate, except for that SVE, that is special visceral efferents. So special visceral efferents, that is the branchial arch muscle related ones. Rest all are connected as nervous intermediates. That is, all the sensory things are connected as nervous intermediates. So as you could see, SVA is for nucleus tractus orientarius, and then it is for the taste sensation. General somatic efferents is for the posterior auricular part, and then concha, all the sensations are from the general somatic efferent. General visceral efferents, all the glands, glandular events, all those things. So So crying and then all those things are mediated by means of your particular this general visual difference. That is the greater superficial petrosal nerve and also your chorda tympani, general visual difference, which are helping in formation of saliva.
The large SVE component remains physically distinct from the nervus intermedius.
So this is something like corona patient. They are separated. Okay, they are isolated. Special visual efferent is like your only motor component. So that is branchial arch component. Part branchial arch 2, that is special visual efferent.
After passing through the internal acoustic meatus, all components of the facial nerve travel in a bony tunnel.
So as you could see, they go inside and then go till this level. So medial part of the internal acoustic meatus is called as porus. Lateral part is called as fundus. So medial porus, lateral fundus. As you have seen, the acoustic neuroma, they go from here to here, this side to this side. Is it or not? Or they can go from here to here towards this particular cerebellopontine angle. So whatever here is a pontomedullary junction will be there in the posterior cranial fossa. As you could see here, this greater superficial petrosal nerve, which is a branch of geniculate ganglion, the green color is going forward like this. As you know, this is going to join with the deep petrosal nerve to the foramen lacerum. So greater petrosal nerve with the deep petrosal nerve, foramen lacerum, they form the VDN nerve, VDN canal. So they go forward. So then for pterygomaxillary, for pterygopalatine fossa, toward the pterygopalatine fossa. And then rest of the sensory muscles, the rest of the things that are going to be carried like this, and then they form the nerve to stapedius and chorda tympani. So we'll follow this video once again.
Within the petrous part of the temporal bone, called the facial canal.
In this facial canal, as you could see, so it is also called as fallopian canal. So petrous part of the temporal, longest canal in a bone which is carrying a nerve is there only in petrous temporal bone, the whole of the body. So longest canal carrying a nerve. That is why it has to have one specialty called as ENT surgery, that is the otorhinolaryngology. So it has to be handled by ENT people. We can just decompress. If any problem is there, any part of this particular course of the facial nerve, we do some surgery called as decompression. When pressure is there, when compression is there, you do something called as decompression. That is called as decompression surgery.
The facial nerve travels a short distance anterolaterally in the facial canal before making a sharp posterior bend or genu.
So this is a genu or the geniculate ganglion which is going to bend posteriorly, as you could see here. So geniculate ganglion, so which consists of only sensory ones only. So geniculate ganglion are most commonly sensory ones only. So of course this nervous intermediate of Risberg, it goes till the lateral part and then once again it joins. Sometimes it may join, sometimes it may not join. Most of the times, so the genu is formed by both of them, and then the one which is sensory related to this goes as greater superficial petrosal nerve.
This bend marks the location of the geniculate ganglion.
So GSPN, that is greater superficial branch, petrosal nerve is a branch of GG. You should remember this sentence. GSPN, that is greater superficial petrosal nerve, is a branch of GG, geniculate ganglion. GSPN is a branch of GG, geniculate ganglion.
As we mentioned, the geniculate ganglion is the home of the cell bodies of the sensory neurons that contribute to the...
So that is sensory neurons only. The sensory ones only, geniculate ganglion, they form. Okay. So not the motor ones. Most of the times, especially you can go for this greater superficial petrosal nerve, which is a branch of GG.
Facial nerve. Facial nerve axons conveying motor innervation travel through the geniculate ganglion as fibers of passage. That is, they pass through the ganglion without making synapses.
So motor ones will not make any synapses over here. As it is, just they go like this. So as you have seen that, that particular motor ones, that is special visual efferents, they have nearly 9,000 fibers, and rest all sensory ones, they all combined to form have got nearly 5,000 fibers. So 9 plus 5 or 14,000 fibers as an average.
Distal to the geniculate ganglion is where the facial nerve components begin to diverge. First, the tiny GSA component of cranial nerve 7 leaves to supply a bit of skin near the ear. Again, there is no clinical relevance to this.
So again, how can you understand this one? Like four friends are coming together and then going together to a trip. They are going, for example, one for mountain climbing, one for swimming, and one for for diving. Okay, and one for aircraft. What is it, jumping. So everyone has got their own option to do something. So the same way, every fiber has got its own option and it is joining together like in a facial canal along with the vestibulocochlear nerve it enters. So the pontomedullary junction, facial nerve, vestibulocochlear. I already told you about the Bill's bar and the Christa falciformis, all those things I covered in the last class. So they are going to form the cross section of the internal artery meatus if you take along with nervous intermediates of Risberg. The facial nerve will be above, nervous intermediates of Risberg will be below, and then below that will be the cochlear nerve, as you could see. Okay. So they are not bothered about that. Right now we are going to see the fiber distribution.
Innervation and its exact course is not important. One half of the GVE innervation leaves to form the greater petrosal nerve, which exits the temporal bone by passing through the greater petrosal foramen. The greater petrosal nerve then drops inferiorly into foramen lacerum.
So as you could say, I already told you the greater superficial petrosal, this particular violet one, it goes towards the foramen lacerum. So lacerum is closed during life, in childhood there is a small like a fissure or something like that. Foramen lacerum. So below which will be the carotid artery. So below which will be the carotid artery, and at the level of foramen lacerum, a lot of things are occurring. So it joins the deep petrosal now, it forms the VDL now. So it is a VDN canal as you could see over here.
To join with the deep petrosal nerve, which consists of postganglionic sympathetic fibers ascending on the internal carotid artery.
So every gland has to have some sympathetic fibers, some parasympathetic fibers. Sympathetic fibers are supplied by one thing. Parasympathetic fibers are supplied by this particular, foramen lacerum through this which the greater superficial petrosal now is going, and then deep petrosal now through the carotid artery. Nearby artery they will have the anastomosis, and that forms the sympathetic pressure. So parasympathetic contracts and helps in the release of secretions, and sympathetic relaxes and then it stops the secretion, something like that. So you should remember like that. So they are antagonistic, as you know that.
Together, the greater and deep petrosal nerves form the Vidian nerve. The Vidian nerve then enters the Vidian canal at the base of the medial pterygoid plate and continues anteriorly until it reaches the pterygopalatine ganglion within the
So this pterygopalatine ganglion is the next destination. Here it was the geniculate ganglion. From here it is the pterygopalatine ganglion, as you could see here. So the next destination of this one is the pterygopalatine ganglion as it goes forward in the pterygopalatine fossa. Where is pterygopalatine fossa? So pterygopalatine fossa, as you could see here. So in front of the pterygoid plates, as you could see here at this part, this is the pterygopalatine fossa. So the pterygopalatine ganglion or spinopalatine ganglion, which is the largest parasympathetic ganglion, as you should know that.
pterygopalatine fossa. Here, preganglionic parasympathetic axons synapse onto postganglionic parasympathetic neurons. These in turn distribute to the lacrimal gland and submucosal glands of the oral and nasal cavities.
So palate, pharynx, larynx, or submucosal glands are supplied by this greater superficial petrosal nerve and also this lacrimal gland. If you are crying, your greater superficial petrosal nerve is acting, and then so it supplies through this one. How does it go? Means from here it has got multiple connections. Once again, it goes to zygomatic nerve, which is a branch of this trigeminal nerve, and then go from zygomatic to temporal, and then it forms it joins the it forms the lacrimal nerve, and then it goes there. So the superior orbital fissure. So contents of superior orbital fissure also you should be knowing. So through the superior orbital fissure it reaches the lacrimal gland. These many multiple destinations are there for this.
The second half of the GVE innervation and the SVA taste sensation combine to form the chorda tympani nerve. Chorda tympani exits the skull by passing inferiorly through the petrotympanic fissure to enter the infratemporal fossa. Here, chorda tympani joins with the lingual branch of.
So normally chorda tympani is there between the handle of the malleus and body of the incus. In between that it runs there. So you could see like a cord. So from the posterior part of the middle ear, it goes towards the anterior part of the middle ear.
Cranial nerve 5. And together these nerves travel anteriorly deep to the.
So it goes from the facial nerve towards the anterior part of the middle ear, and it goes towards the infratemporal fossa and searches for the lingual nerve, and it joins the lingual nerve, and taste sensation of the anterior tongue are supplied.
Mandible. Along the way, the GVE fibers diverge to terminate in the submandibular ganglion. From here, postganglionic neurons distribute to the submandibular and sublingual salivary glands. In contrast, the SVA taste component of chorda tympani remains with the lingual nerve until it reaches the tongue, where it distributes to the taste receptors on the anterior 2/3 of the tongue. Finally, the large SVE component of the facial nerve gives a branch directly to the stapedius muscle within the temporal bone, then exits the skull via the stylomastoid foramen. It supplies the stylohyoid and posterior digastric muscles, then pierces the parotid gland to distribute to the muscles of facial expression. Note that the facial nerve does not provide innervation to the parotid gland, but merely passes through it.
As I have already told, in between the superficial lobe and deep lobe, it passes through that and it will not supply any parotid gland. Parotid gland is through means of aortic ganglion, that is So inferior salivary nucleus, okay, and then it goes to the aortic ganglion, and then so ninth cranial nerve, it is related to the parotid gland, not the seventh cranial nerve. Secretions of this one is related to inferior salivary gland, and secretions of lacrimal glands are related to superior salivary nucleus, and here it is inferior salivary nucleus. Okay, so it is, for example, anything is there that forms the plexus around the glossopharyngeal nerve, forms the tympanic plexus in the on the promontory of the middle ear, as you know that. So this is to join Bhaskar Medical College. I already told you temporal, zygomatic, buccal, marginal mandibular, and cervicofacial. These are the branches of the facial nerve.
Cranial nerve 9 provides innervation to the parotid gland.
So this we complete with this understanding of the anatomy, as you could see, and then we'll go for the proper of the facial nerve, as you could understand here. Facial nerve. Hello. Hello.
Yes, sir.
Yeah. Are you able to see the PPT?
Yes, sir.
Yeah. We'll start with the understanding of the facial nerve, a basic, and then we'll go to paralysis once again. So Fallopius is the one who had done a lot of work, and the canal for facial nerve is called as fallopian canal. This is a tribute to the scientist. So motor root, sensory root, motor predominantly facial nerve, secretomotor. I already told you, lacrimal, submandibular, sublingual. Taste is anterior 2/3 of the tongue, chorda tympani, as you know that. Sensory, postoral, concha, external auditory canal. As you know, all these things, so you are going to have a small revision. So, and I told you CMLTV 15, 10, 4, 11, 13. So Chief Minister has got a large television. That is the parts of the facial nerve. You can remember like the Chief Minister, large television. So C is the cisternal part. So M is the meatal part, L is the labyrinthine part, okay, T is the tympanic part, and V is the vertical part. These are the parts of the facial nerve, that is especially intracranial, intratemporal, and extratemporal. Intracranial, intratemporal, extratemporal. What I told you is cranial, meatal, labyrinthine, tympanic, and mastoid. Okay, mastoid is also called as vertical. Tympanic is also called as horizontal part. So CMLTV, remember like that. So for even a normal student, you can remember CM. Say, Chief Minister has got a large television. Okay, so cerebral part, the cisternal part, which is in the system, cerebellopondyrangular system. As you know, supranuclear fibers, they are crossed. Okay, as you could see. So at the level of the nucleus is the lower motor nucleus, neuron disease. From there to the lower level is the lower motor neuron disease. So you should have a basic idea of about this facial nerve nucleus, which is there. So which has got the upper part and the lower part. Facial nerve upper part is supplied by dual innervation, that is on both the sides. So if one side also damaged in the cortex, the other side will be supporting. Therefore, upper motor neuron lesions, opposite side, lower half of the face are paralyzed because they are crossed. Okay, you should remember like that. And tympanic part, mastoid part. So size is nearly 15 millimeters, 10 millimeters. 4 is shortest one is the labyrinthine part. So CMLTV. So 15, 10, 4. This is 11. This is 11, and 4, 11, 13. So this is 13 millimeters almost size. Extratemporal will be longer. Whatever from the exit of cellular foramen, it will be like that. As you could see, CMLTV. Don't forget that. So as you could see, so this particular vestibulocochlear nerve also joins with the facial nerve, as you could see here. So if you take that, it is coming like this from a brainstem and then fontomedullary junction and going inside the canal, that is internal artery meatus, and taking a genu. So that is cisternal part, meatal part, labyrinthine part, okay, tympanic part, and vertical part. So this is the vertical part. So as you could see here, the vertical part is giving rise to stapedius, now to stapedius through the pyramid. Till this part, you can call it as the transverse part. So from the geniculate ganglion to pyramid, this part can be called as transverse part. So if you take the lateral semicircular canal of the right side like this, so when facial nerve is running, it runs medial and inferior to the lateral semicircular canal. So medial and inferior to the lateral semicircular canal. It is medial and inferior to the lateral semicircular canal. You could see the carotid artery here, and this is the cochlea here. So at the level of labyrinthine segment, anteriorly will be cochlea, posteriorly will be the ampullary ends of superior and lateral semicircular canals. So anterior at the level of this labyrinthine segment, which is the narrowest and shortest, the anterior will be cochlea, posterior will be the ampullary ends of superior and lateral semicircular canals. Okay, superior semicircular canal and lateral semicircular canal will be the ampulla. So posteriorly, and superiorly will be the tegment tympani. Superiorly will be the tegment tympani, as you could see. So these are all the things that I try to explain in this. Okay, once again you could see the facial nerve going inside like this, internal artery meatus, and then you could see that this is the incus, and then this is the malleus. So from the lateral side, if you are going, so this is the tympanic membrane. From lateral side, if you are coming, you have got the external auditory canal, tympanic membrane, malleus, and incus. If incus is intact, the facial nerve is protected. You could see that. Okay, incus is intact, facial nerve. It's like a hero protecting the heroine. Incus is the hero, and then facial nerve is the heroine. Until you have to touch the heroine means you have to kill the hero. Then only you can touch the heroine. So that is the same way. Incus is protected means incus is suspended in the fossa incudis. Therefore, it is protecting the facial nerve. When incus is removed means your facial nerve is exposed outside. So once again, you could see it here. Okay, pons, the internal artery matrix is going in and entering inside like this. So this is the labyrinthine segment is the narrowest and shortest part. So the labyrinthine segment, so from here to here. So this is the medial porus. This is the lateral fundus. From labyrinthine segment from fundus to GG. So labyrinthine segment extends from fundus to GG, fundus to geniculate ganglion. Labyrinthine segment extends from fundus to GG, fundus to GG, fundus to geniculate ganglion. What is the medial part of the internal acoustic meatus called as porus? What is the lateral part of the internal acoustic meatus known as fundus? So from the fundus to GG, it is the labyrinthine segment. It is the narrowest and shortest segment. So as you could see, CMLTV 1510 4 millimeters is the length of this, and the diameter is 0.6 millimeters in diameter. 0.6 millimeter in diameter. Therefore, whenever there is any edema or anything, so whenever there is any edema, you will have the labyrinthine segment is compromised, and then there will be compression and leading to facial palsy, especially Bell's palsy, causing edema and then leading to facial nerve palsy over here. Okay, that is the edema. What is this, Ray? You should be understanding that one. Okay, so this is the tympanic segment. So whenever the tympanic segment is from the geniculate ganglion till the level of pyramid. So vertical segment from the pyramid to the stylomastoid foramen, as you could see below the pyramid to the stylomastoid foramen. So tympanic segment is almost not having any branches over here, and tympanic segment it lies below the lateral semicircular canal and above the stapes. So below the lateral semicircular canal and above the stapes. So this is the greater superficial petrosal nerve, as you should know already. So what are the branches of the facial nerve, as you could see? So G and C, the greater superficial petrosal nerve is the number one. Number two, nerve to stapedius, which is the motor nerve, and number three is the chorda tympani. Chorda tympani arises 5 to say 7 millimeters from the stylomastoid foramen within the canal itself. So this is this much long canal from here till the level of here till the level of here. This is a long canal, longest in the body, of course, carrying a nerve. And this is the stapes, as you could see here. So once again, understanding within the internal artery matrix, how does it lie? It means so it is going to cross it something like that. So as you could see, this is a facial nerve. Go back once again, facial nerve. So this is cochlear nerve. So as you know that 7 up and coke down, 7 up and coke down. Anterior superiorly is the facial nerve, anterior inferiorly is the cochlear nerve. Posterior superiorly is the superior vestibular nerve, posterior inferiorly is the inferior vestibular nerve. So this is the anterior part, this is the posterior part, as you could see over here. So once again, they might cross it medially and laterally, as you could see from here to here. They are entering like that, and then they are going till the level of below the level of, I told you, medial and inferior to the lateral semicircular canal will be your facial nerve. So this is the transverse section of that, as you could see, transverse section of internal artery meatus. So this is the anterior, this is the posterior. 7 up, 7 up, 7 up. You should remember 7 up, and this is cochlea is down, coke down, and superior vestibular nerve is superior, and inferior vestibular nerve is inferior. So transverse crest will be there. This is the crista falciformis, and then vertical crest is called as Bill's bar. You should remember this diagram. I hope you can take a screenshot of this. So this is the inferior vestibular, and this is singular foramen, especially sing is king, and then this is the posterior semicircular canal. So I told you BPPV, you can just go for excision of the singular foramen, excision of the posterior vestibular nerve. That is singular foramen separately going there. Parts of the facial nerve I have seen intracranial, intratemporal, CMLTV. I told you already all these things, intraparotid and extraparotid. So all these things are covered. You will have just in a word wise. Segments of the facial nerve, supranuclear and the cortex to brainstem. Brainstem, motor nucleus, as you know. Intracranial, I told you already the sizes of this CMLTV 15, 10, 4, 11, 13. Nearby I told you 15, 10, 4, 11, 13. You can remember like that. So mastoid is pyramid to stylomastoid foramen. Extratemporal is stylomastoid foramen to pes anserinus, as you could see. Answer is like a goose foot here, okay, as you know that. So primary branches of the facial nerve, as you could see, that intratemporal, as you know, G and C, I told you. So G and C, like greater superficial petrosal nerve to stapedius and chorda tympani. Now, extraparotid is postauricular, stylohyoid, posterior of diagnosis. There are muscular branches, and intraparotid TZ, B and C, as you know that. To join Bhaskar Medical College are temporal, zygomatic, buccal, marginal mandibular, and cervicofacial. As you could see, once again, the same intracranial branches, as you could see that, this is, no, now to stapedius is something, and this is chorda tympani, this is spinoparthenia. As I already told you, Greater superficial petrosal nerve joins the sphenopalatine ganglion. It goes to lacrimal gland and nasopalatal gland, palate, pharynx, larynx. Almost all these glands are supplied by that. And then the taste sensation, alternate taste pathway is through means of greater superficial petrosal nerve. You can keep it in mind like that. And now the stapedius is this one. Okay, now the stapedius is going to contract when 90 decibel sound more than that is heard. Now the stapedius is going to contract through the pyramid. It is going inside. And this is a chorda tympani, enter 2/3 of the tongue and then submandibular sublingual glands. So once again, TZBMC, as I already told you, styloid muscle and posterior belly of digastric. Anterior belly supplied by fifth cranial nerve. Communicating branches, so as you could see in the meatus, they have got connection with vestibular cochlear nerve. As you could see, this link is related to your Ramsay hand syndrome. As you could see that there are vesicles in the external aortic canal. You have got a facial palsy also. Tympanic branch, lesser petrosal nerve. Through the lesser petrosal nerve, through the aortic ganglion, it connects to the parotid. It connects to the parotid. Of course, direct connection is not there. In tympanic segment, there is a lesser petrosal nerve. Okay. So there is one more nerve called as the external petrosal nerve also, which is joining with the middle meningeal artery. Of course, that is of least importance, not related to that directly. So greater petrosal nerve, lesser petrosal nerve. Greater petrosal nerve for crying, and then for crying there is lacrimation and taste of the anterior part of the hard palate and also soft palate. And this lesser petrosal nerve is for the parotid gland. You should have it in mind. Aortic ganglion, through the aortic ganglion, that is inferior salivary nucleus. And that is external petrosal nerve, which is through towards the middle meningeal artery. Okay, it goes towards the middle meningeal artery. Of course, the Masseter segment, as you know, auricular branch of vagus, it has got connection with the auricular branch of 10th cranial nerve. Extra parotid is glossopharyngeal, auriculotemporal, vagus, greater auricular, lesser occipital, terminal branches, branches of the trigeminal nerve for your proprioception, sensation, and all. So all these things are very important. So I have got connection with all the nerves, as you could see here. Surgical landmarks are the next important things that are there. Processus cochleariformis, as you should know, processus cochleariformis, it is very important. The small bony protuberance from the tensor tympani muscle, as you know, so anterior superior part of the middle ear, you have got processus cochleariformis. Then the tensor tympani muscle gets attachment to this one, as you know that. So it insert to the neck of the malleus. As it is, this nerve lies 1 millimeter inferior to the genicular ganglion. Okay. So lies 1 millimeter inferior to the genicular ganglion at the anterior end of the tympanic segment. As you could see, this processus cochleariformis is inferior to the genicular ganglia. So if you go to the processus cochleariformis and start drilling, you reach the this genicular ganglia 1 millimeter superiorly. So processus cochleariformis is inferior. Therefore, superiorly, if you drill, you get this genicular ganglia. So then one more thing is cog. What is cog? Actually, it is hanging from the tegment tympani. So attic region, there is a small vertical projection called as cog. So it is lies 1 millimeter above and posterior to the cochleariform process. The cog and cochleariform process are important landmarks, as you could see. And short process of the incus, it is 2 millimeters below the external genome. So 2 millimeters below the external genome. So short process, external genome is the second genome, as you could see. The short process of the, I told you, incus is there in the incus buttress like this. Medial to the incus will be your facial nerve. So until you reach the incus, you damage the incus, you cannot reach the facial nerve from laterally. That is the importance of this. And lateral semicircular canal, as I told you, medial and inferior to the lateral semicircular canal will be the this particular facial nerve. And oval window, as you could see. So this is the oval window, and this is the lateral semicircular canal, as you could see. Lateral semicircular canal. In between goes the facial nerve. So lateral semicircular canal and oval windows. In between goes the facial nerve. So you can just imagine like that. These are all given in your textbook, but this is in understanding manner that. So inferior edge of the posterior semicircular canal. As you could see, behind will be the posterior semicircular canal. So behind the facial nerve will be the posterior semicircular canal. And you have to remember this tympanomastoid suture also. Tympanomastoid suture, as you could see, the facial nerve runs behind, that is behind the external auditory canal medially. So tympanomastoid suture, if you go 5 to 8 millimeters medially, you will get the mastoid segment. That is the vertical segment. So the facial nerve goes like this in the canal, goes back, the first genu comes down as second genu, as you could see. After the second genu, it passes behind the external auditory canal, That is behind the tympanomastoid suture. You should understand that. Digastric ridge in the mastoid tips. If you go to the digastric ridge, you drill the mastoid till the medialmost part, you got something called as digastric ridge, wherein the digastric muscle, that is digastric ridge is there. Posterior belly of digastric is attached to that medially. So you could trace it to see the facial nerve. So groove between the mastoid and bony ESC meatus bisected by the facial nerve, as you should see. And there is something called as tragal pointer. Tragal pointer, the tragus, if you, when you are dissecting and the tragus is showing the facial nerve, almost like 1 centimeter anterior-inferior will be. If you go inside and then open it, tragus will be showing the facial nerve. That is 1 centimeter anterior-inferior. That is very important. Styloid process is medial. Actually, remember SPM. Styloid process is medial to facial nerve. SPM is medial to facial nerve. That is, facial nerve runs lateral to the styloid process. And if you trace the posterior belly of digastric superiorly, you find the facial nerve. So trace the posterior belly of. These are all the things that are there. There are 10 landmarks you should remember by heart and tell whenever asked. It's given in the textbook. You can understand that easily. So as you could see, surgical landmarks, as you could see here, this is a cartilaginous pointer which is pointing towards the facial nerve, as you could see. And digastric muscle, if you go like this superiorly, you can find the facial nerve here. And this is a parotid gland, as you know. And this is a process cochleariform is, if you go anterosuperiorly 1 millimeter, you drill it here, you find the facial nerve, first geniculate ganglion. And below the lateral semicircular canal and above the oval window, you could see. And behind the pyramid. So these are all the things that are there. I told you the rainbow concept. This rainbow is coming up and down. And this is the promontory with like a tree, as I told you. Promontory has got tympanic plexus, and then this is the oval window. This is the round window, as you could see. So, and this is the pyramid, as you could see. So, pyramid, promontory to pyramidal process, something called as ponticulus. This is the ponticulus ridge of bone. And subiculum is something over here. So, lip of the round window to styloid eminence. So, lip of the round window to styloid eminence, this is the subiculum. In between the pyramid and superiorly pyramid, inferiorly subiculum, there lies the, as you could see, sinus tympanus, something which is medial to the facial nerve, which is site for the cholesteatoma debris that is to be left out during surgery. So these are all surgical landmarks, very important. So lesions of the facial nerve can be supranuclear, nuclear, CP angle, suprageniculate, suprastapedial, supracaudal, infracaudal. Anywhere the lesion can occur in facial nerve. So supranuclear, upper motor neuron lesion. Supranuclear is upper motor. Nucleus belongs to lower motor neuron. Upper motor neuron lesion, opposite side, lower half of the face paralyzed. So upper motor neuron lesion, opposite side, lower half of the face paralyzed. Upper motor neuron lesion, opposite side, lower half of the face paralyzed. Lower motor neuron lesion, entire side, same half paralyzed. Just remember like that. So there is a hemiplegia. You can have this upper motor neuron lesion. The supranuclear lesions can be there. Opposite side, lower half of the face paralyzed. And there is crossing the fibers at the level of internal capsule. As you know that you should relate it with your medicine. Okay, and that is neurology also. Okay. So nuclear lesions, for example, if nucleus is having a connection with the sixth cranial nerve also. So it is having a connection, and as I told you, neurobiotaxis last time only. So you can have nuclear lesion that side only paralyzed. Okay, at CP angle. So at the cerebellopontine angle, there will be linked with all these nerves are there 5, 7, 8, 9, 10, 11, 12, all are there. One below the other. There is a CP angle, cerebellopontine angle, where it is related to all these nerve palsy. Suprageniculate, that is above the geniculate ganglion, lacrimation is lost, hyperacusis, loss of taste will be there. Lost. Suprastapedial. Suprastapedial means at the level of stapedius, you have got hyperacusis, that is, stapedius muscle is not contracting and loss of taste will be there. Supracaudal is loss of taste. So at every level there is an injury, there is a loss of the particular sensation which is below that level. For example, below the stapedius there is a problem. You can have a problem in the taste, but stapedius is functioning. The lower level is lost, upper level is intact. So infracaudal facial asymmetry only. When it comes to outside and while doing the parotid surgery, facial nerve is cut. There is only paralysis of facial nerve on the face, but not the other things that are related to taste or related to stapedial reflex. All are intact. So upper motor neuron lesion, upper motor bilateral innervation is there. The nucleus of the facial nerve is innervated bilaterally. So opposite side, lower half of the face paralyzed. So left upper motor neuron lesion, opposite side, lower half of the face paralyzed. That is right side, lower half of the face. Lower motor neuron lesion, entire side, same half of the face paralyzed. Lower motor neuron, entire side, same half of the face paralyzed. Upper motor neuron on the right side, left side, lower half of the face paralyzed. Just remember like this. So as you could see, upper motor neuron palsy, lower motor neuron palsy, I told you already. So etiology of facial nerve palsy, if we take idiopathic is the most important, Bell's palsy is the most important cause of it. Idiopathic palsy of unknown origin, acute onset, you have to, this is the diagnosis of ruled out. Okay, diagnosis that is ruled out. So the idiopathic trauma, road traffic accidents, infection like CSOM, herpes zoster urticus, malignant otitis externa. And neoplasm is parotid tumors, acoustic neuroma, glomus. Any tumors affecting the facial nerve can cause congenital causes like Mobius syndrome along with sixth cranial nerve is occurring. That is lateral rectus palsy. Iatrogenic causes like mastectomy and parotid surgery. During surgery, you can damage this. And metabolic causes like diabetes mellitus and hypertension are also going to cause. So most commonly bilaterally it will be there, especially in something like sarcoidosis or Guillain-Barré syndrome, bilateral facial palsy. Sunderland is the one who has classified this. As you know, axon will be there, surrounded by endoneurium, surrounded by fascicles of perineurium, and at the end of the day, epineurium. So there is something called as when there is pressure on the nerve, so that is something related to only conduction block. When there is cutting of the nerve, that is completely related to the transmission itself is not. The pressure is relieved easily. That is called as neuropraxia, as you should have an idea in it. So endoneurium, perineurium, epineurium, myelin sheath. So exoplasm is the center one, and myelin sheath is one. Myelin sheath, endoneurium, perineurium, epineurium. Based on this only classification is done. Neuroplaxia, partial block of exoplasm. Axonotemesis is injury to the axon. Neuronotemesis is injury to the endoneurium or myelin sheath. So axonotemesis, neuroplaxia, axonotemesis, neuronotemesis, partial transaction, complete transaction. Okay, partial transaction and complete transaction. These are 5 grades that are there, very important. Neuroplaxia, axonotemesis, neuronotemesis, partial transaction, complete transaction. So right from the previous picture you can understand. So neuropraxia, axonotemesis, okay, neuronotemesis, okay, partial transaction, complete transaction. You could see here 1, 2, 3, 4, 5, 6. So the paralysis can be occurring neuropraxia, axonotemesis, neuronotemesis, partial transaction, complete transaction. So this is 1, 2, 3, 4, 5. These are grades that you can understand it easily. There's something called as House-Brackman classification 1 year post-injury. You can have normal. This is the grading of facial palsy. That was the grading of injury. This is grading of facial palsy. Normal, mild, moderate, moderately severe, severe, total. Total palsy, no movement. So complete closure with effort is grade 3. You can have in mind. Complete closure with effort is grade 3. So you can have it that. So these 4 grades they recover easily. 5 and 6 grade they recover with difficulty. Okay. So something which is related to that, we are not going to details of this Sunderland grading and House Bragman grading. I told you 3 and 3 and 4 and 4. Till this level, it is good. Okay, less than 10% of the normal, 2 to 4 months recovery begins. Till this level, it is good. Beyond that, it is a bad thing. So diagnosis of the facial palsy. How do we diagnose? This is topo-diagnostic tests. What is the topology? Where is the lesion? You can see topo-diagnostic test. Electrical diagnostic tests. Okay, topo-diagnostic tests, electrical diagnostic tests like electro-neuronography, electromyography are the most important. Okay, most important. We are going to deal all those things. And magnetic stimulation of the facial nerve and CT scan, as you know, for progressive palsy, MRI brain and surgical exploration. Based on this, you do the diagnosis. Audiometry you should do for cochlear nerve function, vestibulometry for vestibular function. Schirmer's test, you put some tissue paper inside the lower fornix and then you see for the greater superficial petrosal nerve function whether it is getting wet or not. Stapedial reflex test, so you are going to do the stapedial reflex whether it is functioning or not. Electrogustometry, taste at the anterior tooth of the tongue you can do by closing the eyes. And submandibular salivary flow, whether you have to insert a tube into the submandibular gland and you can see whether it is going to have some salivary flow or not. Examination for terminal facial nerve branches. So you know how to examine the terminal facial nerve branches, as you know that. Okay. So as you could see, some cortex till this level, there are many things that are there. Central examination, neurological examination, CT scan, with this, and MRI, electro-neuronography, with the nerve, and then audiology, CT scan, and tear test, as you know, the Schirmer's test, stapedial reflex, taste, and salivation, as you know. Facial movements, you can see. So Schirmer's test, as I already told you, the details of which you can read. Of course, in 5 minutes, you can see more than 30% difference, and you can find it something difference in the geniculate ganglion. Stapedial reflex, as you know, 7th cranial nerve is involved, 8th cranial nerve is involved, superior orbital complex is involved, as you know. The stapedial reflex is a part of tympanometry, right? Stapedial reflex means you have to write about reflex, not about tympanometry. Electrogustometry taste can be known. Muscle supplied, as you know, frontalis. Just a moment. Hello. Hello. I'm class. I'll tell that. After half an hour. I'll see you in 10. Okay. After half an hour, I'll talk. So as you could see the testing of the nerves, as you could see, you know how to test the nerves. This is frontalis, orbicularis, oculi, levator, labia superioris, eloquenesi, and then zygomaticus major. You smile means zygomaticus major. Depressor anguli oris, okay. Depressor labia inferioris, platysma, as you know how to test the platysma. You have to test it like this. So all these nerves, as you know, all these things can be supplying. So almost nearly 40 to 43 muscles are there. You can test everything, blowing of the particular cheeks and all, everything can be seen. Okay. Electrical tests, we have got the nerve excitability test. Like there are 4 tests here: minimal nerve excitability test, maximal stimulation test, electro-neuronography and electromyography. Minimal nerve excitability test, maximal stimulation test, electro-neuronography, electromyography. Here, minimal nerve excitability test and maximal stimulation tests are not that important, but whereas electro-neuronography and electromyography are very important. Electro-neuronography helps us to see in 2 weeks, electromyography helps us to see in 3 weeks. The concept I'll try to tell over here is minimal nerve excitability test. You have got, you have to see the twitch, compare on both sides. So difference between the currents that are there on both sides is more than 3.5 milliamperes. It is unfavorable prognosis. So whether it is a conduction block or degeneration, you want to know with these tests, all these tests. Okay, minimum current that is required to produce a twitch is calculated. If current on this side and this side are compared and difference between these two is 3.5 milliamperes, it is unfavorable prognosis. Remember like that. First one, minimal nerve excitability test. Second one is maximal stimulation test. So as you could see, so equal, decrease or absent. There are three responses that you can say: equal, decrease or absent, maximal stimulation test. Equal, decrease or absent. So this is also not very important test. Second test is maximal stimulation. First one is minimal nerve excitability test, maximal stimulation test. Equal, decrease or absent. You compare with the both sides. Not very important. Electro-neuronography is very important. So as you should know, the electro-neuronography, it is evoked myography. Okay, evoked myography. Whether it is functioning with that or not, you should with some evoked myography. As you could see, the nerve is there. You are testing the nerve. Electromyography is you are testing the muscle directly. Electromyography. So whether it is stimulating or not, you could see. So paralyzed side is compared to the normal side here, it is taken as 100%. If the response is greater than 10%, the chances for recovery are there. Response is less than 10%, 25% chance of recovery. So as you could see, so the electro-neuronography, you are trying to give some stimulation to the this particular nerve and then check it. Okay, so you could see the electro-neuronography here in this way. And last one is the electromyography. Electromyography, the activity. So you are injecting a needle, putting a needle into the orbicularis oculi or orbicularis oris somewhere and then seeing its activity. So normally, so whenever the muscle is going to have some injury, it is going to have some degeneration. Degeneration sets in. So normally, the muscle has got some conduction. If degeneration is setting it, so there is something called as polyphasic reinnervation potentials. Polyphasic reinnervation is occurring after injury. Polyphasic reinnervation potentials are calculated in this electromyography. They are called as PRP. So Prajarajam party of your Chiranjeevi or something like that. So PRP, so polyphasic reinnervation potential. It is something like that. Polyphasic reinnervation potentials are generated means the nerve is recovering from injury. That is the concept over here. And then second thing is fibrillation potentials. Fibrillation potentials are there means the nerve is not going to have that much of generation, but there is some amount of response. Okay, electrical silence. Third one is electrical silence. No response at all. So electrical silence, fibrillation potential, polyphasic reinnervation potential. There are three things that are there in the electromyography. So electromyography for 3 weeks and electroneuronography for 2 weeks at the end of the day. And minimum, if you take all the paralysis, then at least 5% of the cases you have to repair. So 5% of the cases you have to go for repair. So do this test at the earliest, every once a day or daily or after every 2 days. Within that activity, you can go for it and then see that. Okay. So electromyography. So you could say electrical silence is the third one. The worst thing that can happen. This is a normal one. This is a polyphasic reinnervation potentials. So that is occurring after reinnervation is occurring. And fibrillation potentials, there is some amount of response. So normal motor action potentials, an incomplete transaction of the nerve, there will be normal motor unit potential. So reinnervation is occurring means it is a good sign, that is polyphasic reinnervation potential, and fibrillation potentials is that is denervation is occurring. Electrical silence is it has gone completely waste, useless. Next part of the discussion is about our Bell's palsy. So Bell's palsy, as I already told you, most important classification of the facial nerve, about 60% to 70% of the facial nerve palsy are idiopathic. And among all the reasons of the facial nerve palsy, 75% of the cases are Bell's palsy. Almost 3 out of 4 cases of facial palsy are Bell's palsy only. Important is the definition: acute, idiopathic, unilateral, self-limiting, non-progressive peripheral facial nerve palsy is called as Bell's palsy. Acute, idiopathic, no cause, unilateral, one side. Of course, bilateral can occur in 10% nearly, and 10% can be familial also. 10% familial and 10% bilateral also. It is self-limiting palsy. It goes by itself, non-progressive, peripheral facial. For example, someone is going in a bus without protecting to the ears. So the chilledness because of the lateral that is particular transverse segment of the facial nerve, especially days end. For example, because of chilled weather, also they can have a facial palsy that is called as Bell's palsy. That can be called, or else viral infection. Okay, viral infection, vascular causes can cause. Okay, and then it can be autoimmune also. Okay, so viral, ischemia, hereditary, it can be hereditary in 10%, I told you, and autoimmune also it can be there. So they start recovering in 3 weeks most of the time. 95% recover, and because of exposure to cold, emotional stress, nerve compression, etc., all these things are the reason. Virus is herpes simplex, herpes zoster, and Epstein Barr virus. So Charles Bell is something. There is something called Bell's phenomena also. When the eyes tries to close, the lid, the eyelid, eyeball turns upwards to protect it from exposure keratitis. So if the external, this particular orbicularis oculi is not functioning, you can see the Bell's phenomenon also. So clinical features, as you know, unilateral palsy, as I told you, lower motor neuron palsy, as you know, onset complete face is gone. So inability to close the eyes, wide palpebral feature, epifora, loss of nasolabial fold, it will be like this. The opposite side will be overacting, and then it is pushed towards the other side. Left side, right side palsy means the opposite side will be overacting, and then when you ask him to frown, he will be like this one. Okay, so he will say like this, and then when you ask him to blow the mouth, he will do like this. Opposite side will be functioning more because of the overaction, and loss of drooling of saliva will be there. Food will cannot be chewed because of buccinator involvement. All the muscles almost like these are all supplied by means of superior poly innervated, and then except for the buccinator and except for the this particular mentalis muscle. Okay, except for mentalis which are supplied from inferiorly. So that is one important finding during the supply of the facial now. So all these muscles they go into paralysis. So medical treatment is by prednisolone, 1 mg per kg body weight. So there is a regimen for this. There is also something like acecloprid they can give. Acecloprid is anti-herpetic drug that you can go for 400 mg 5 times a day for almost 1 week. Eye closure, voluntary closure, along with you should ask the plaster to be put on the eyes because eyes goes into exposure keratitis, and you can go for Mizol eye drops also. Next, physiotherapy is for the patient's satisfaction. By massage, it will stimulate the muscles to act actually. Next, electrical stimulation of the facial nerve and muscle, and facial nerve decompression if it is needed. Sometimes very rarely we have to do. So we have to stimulate the muscle, and these are all the treatments for this one. Mobius syndrome, as you could see, if sixth cranial nerve is also involved along with seventh cranial nerve, it is called a Mobius syndrome, congenital occurring. Melkerson-Rosenthal syndrome associated with facial palsy, recurrent facial palsy, fissure tongue, and lip edema with a family history. It's called Melkerson-Rosenthal syndrome, as you could see it in this. So surgical treatment for facial nerve palsy. Of course, there are many reasons for facial nerve palsy. As you should know, the table is there in the textbook. You can see that the central causes like as you could see, so like pontine gliomas, okay, and then brain abscess can be there, and then poliomyelitis can be there, and then all those things, meningiomas, all those things can lead to facial palsy. More common is the Bell's palsy. They will put the focus on this one. So they can be bilateral facial palsy also. So there are different types of palsies. What are the reasons and all? You can see in the textbook. The reasons are there to be discussed as a part of table, and you have to learn the table. That is not of very importance to understand in the. So not much of discussion I'm going into that. So facial nerve decompression. So what are the ways that you can treat the facial nerve palsy? You can go for example, compression is there. You can go for decompression. So that is a till the meatal foramen. You have to decompress. Neuroraphy, that is nerve repair. How can you repair the nerve? If there is a cut of the nerve, you can just put end-to-end anastomosis. Or else, if two parts are there like this, there is a gap in between. You can take a greater auricular nerve or a sural nerve, or especially nowadays, you can take any part of the sural nerve, more commonly taken. You can suture it end-to-end, and it will get repaired more commonly. Nerve transposition. One more nerve is taken and then put into the facial nerve, so that especially more common nowadays, masseter muscle is taken. Of course, the hypoglossal nerve is given over here. Hypoglossal nerve causes the palsy of the tongue, therefore it is not being used nowadays. So especially the masseter nerve nowadays being done. So if muscle is not at all functioning, the transposition of the muscles can be done. Temporalis can be taken and then put it over here, and masseter muscle. And muscle flaps can be done. Static procedures can be there. If eyelid is not drooping, you put a gold implant, 1 gram gold there, and then you can go for the eyelid implant or facial slings. So these are all different operations that are being done. So up to 3 weeks, for example, if the patient has got an injury, trauma-related facial palsy. Trauma-related facial palsy is very important. You should have a basic idea about it. So transverse temporal bone fractures and the longitudinal temporal bone. Longitudinal temporal bone fractures, they go from lateral blow, the fracture line passes like this, and then towards the foramen lacerum. Transverse temporal bone fractures from posterior below the fracture line passes like this and it cuts the facial nerve. More commonly, transverse temporal bone fracture has got facial nerve palsy. So longitudinal temporal bone fractures has got hematoma, etc. Only 10% chance of facial palsy, whereas transverse temporal bone fracture has got longitudinal. In such a situation, if the patient is having acute facial palsy at the time of the injury itself, you have to go for a repair then and there. If it is developing after a long time, you can wait for some time and then you can go for the repair of the facial nerve palsy. So as you could see here, the treatment protocol is nerve decompression or nerve repair up to 3 weeks. That is the earliest thing you have to go for decompression of the nerve or nerve repair. 2 weeks to 3 years, you can go for nerve repair or transposition. So nerve repair, the decompression is not done at that. More than 2 years with fibrillation potentials, you have to go for nerve transposition. That is not going to recover. Therefore, more than you have to wait for nearly 2 years. And then if fibrillation potentials are there in the electro-myography, you can go for nerve repair or transposition. More than 2 years with electrical silence. If muscle itself is not functioning, nerve is not functioning, electro-neuronography, you can go for nerve repair. Muscle is not functioning, electromyography, you can go for muscle repair. So at that particular point of time, muscle transposition can be done, eyelid transplant or facial skin can be done. Facial and decompression, how it is done means cortical mastectomy done. You have to thin out the barber pole fashion. You have to thin out the nerve. All the bone around the nerve is drilled out slowly. So posteriorly mastoid segment, laterally external, all the things are exposed. So labyrinthine segment is decompressed by middle cranial fossa. Sometimes you put a hole over here and then lift the temporal lobe of the brain and then you see from superiorly you have to drill. That is the middle cranial fossa, which is difficult. So barber polling fashion, as you could see, you have to from here till here, one after the other, one after the other. As you should be showing the facial nerve and then drilling it, and then slowly you have to decompress it. So direct repair, as you could see, within 1 centimeter, if it is there, you can put sutures if any injury is there. So nerves used are greater olecranon nerve, which is in the same field. It is very easy. Or sural nerve can be used at this point of place behind the lateral malleolus of the leg. You can go for sural nerve. So nerve transposition is like you split the nerve transposition is from here you are transferring the nerve. So from hypoglossal you are giving a graft to the nerve this facial nerve. That is the nerve transposition. For example, hypoglossal in the same operative. Nerve transposition can be done if the facial nerve hypoglossal anastomosis can be done for cut facial nerve and you can go for it. Or else you have the masseter nerve itself here, we can go for that. And if muscles are not functioning properly at the EMG, you can go for a scalp incision and then you can shift this temporalis muscle towards this side. So DLI augmentation, there is a crossroad, so you can augment it to the depressor labia inferioris, which is very important. Masseter muscle transposition, as you could see, masseter muscle is also being transposed. Okay, it is slipped outside so that your angle of the mouth is given some support. Gold weight, as I already told you, gold implant can be done for tarsal. If eyes are not getting closed, you can give a weight for it so that gravity-based closure will be there. Complications of facial nerve palsy are incomplete recovery, exposure keratitis, facial tics and spasms. So incomplete recovery can occur, exposure keratitis because eyeball can be involved, facial tics and spasms. Synkinesis is mass movement. So sometimes when the person is sitting in a, for example, in a restaurant and then is asking for some order. So by seeing lady waiter is trying to see her and then ask her to come here like this. He is he is trying to move his mouth and his eyes are, winking. So there is a cross connection that is occurring. Lady waiter comes and hits him. So because of this, social problems occur. So that is what is called as synkinesis, mass movement of facial muscles, like as if he is blinking and then winking towards someone who is not intended. So that is causing social problem. That is faulty regeneration. Next, gustatory lacrimation and gustatory sweating. Very important. These two things are crocodile tears. Crocodile doesn't cry actually. We feel like so. What happens is when salivary glands are linked to lacrimal glands. So when you are eating, so what happens is the lacrimal glands start crying. So there is injury over here. For example, the fibers, the parasympathetic fibers, faulty regeneration occurs towards this lacrimal gland. So that forms the crocodile tear syndrome. Very important for 2 marks. And you have got Fraze syndrome also, gustatory sweating. It is also called as gustatory sweating. When you are eating, so this is faulty regeneration of secretive motor to sympathetic crossover that is occurring. That is called as Fraze syndrome. So tympanic neurectomy, you can go for it, and then that is the treatment of choice for that. So this is how the facial nerve has to be understood basically as a part of paralysis and all, you can read that textbook once again. There is a lot of things to be understood in facial now. At a time, one day you cannot master it as it is, because you need to understand the anatomy first. That's why I took a lot of time for the anatomy, and you could get something because of that anatomy. You could get the understanding of that. Okay. Hello. Hello.
Yes, sir.
Yeah, you got the point right now. And there are a few other points to be discussed. Tics and blepharospasm, all those things are there in the textbook. You can say blepharospasm will be there, so wherein because of basal ganglion problems, and then because of otherwise there are some vascular loop compressing the facial nerve, there will be hemifacial spasms. All those things are there in the textbook. There are minor details you can just read out in that. So once you understand this is all very simple. You can understand that. But most important here is the phrase syndrome or gestational lacrimal crocodile tears, which are asked for 2 marks question, and then later on your greater superficial petrosome can be asked, and later on your course of the facial nerve can be asked, and later on your Bell's palsy can be asked for a 4 marks question. All these things can be there. Read it today itself. I try to supplement some of the things by means of your group so that you can understand the facial nerve better. Any doubt you can ask. Okay.